Welcome back to the Neurocritical Care Society podcast. This is your host, Joshua Levine. In this episode, we are fortunate to have Dr. Mauro Oddo return as a guest. He discusses with Dr. Brogan the recent consensus statement by the European Society of Intensive Medicine on fluid management in the neuro-ICU. Here's the interview.
Hi, this is Mike Brogan. I'm a neurointensivist at Regents Hospital in St. Paul. Today I'm interviewing Dr. Mauro Oddo from Lausanne University Hospital in Switzerland. We're going to discuss his recent paper in intensive care medicine titled Fluid Therapy in Neurointensive Care Patients, ESICM Consensus and Clinical Practice Recommendations. Dr. Oddo, first of all, welcome back to the NCS podcast series. It's good to have you again.
Thanks for inviting me.
Before we get into any specific recommendations, can you provide our listeners some brief context? Why is this paper important?
Well, I'm happy to see that you consider this as important. It was for sure an important work in terms of the time, the energy, and the fact that the main issue was to try and find a consensus where there is actually no large evidence. And this was a little bit surprising, because we use daily fluids in intensive care patients and, of course, in neurointensive care patients. And yet we don't have actually evidence for several reasons we can discuss later on, mainly because those patients are often actually excluded from large trials. So we felt that this was a very important daily issue in routine practice. There was definitely a gap in terms of evidence. Therefore, we built up a consensus.
And in this paper, it may be different in the methodology than some other papers that folks have read. Consensus for this paper was based on integration of available evidence from a literature review as well as expert opinion. Can you describe this process and what thresholds were used?
Yeah. Well, first of all, let me take this opportunity based on this question to thank everyone involved in this consensus. These were physicians who see neuro patients regularly, but not only neurointensivists. The second comment, we are very grateful of having on board Daniele Poole, who is the co-author of this paper with me. He's intensivist, but very skilled in methodology. And then we follow the principles of the grade system, which is to sort of assess the quality of evidence. We divided the group in 3 parts based on the topic. Then we did a systematic search. Then it was the grade which was applied, and there were questions that were then formulated. So first of all, the grade is based on the evidence. Now you ask me, but there was low quality of evidence. So what do? It's what we call the modified Delphi process, which is based on integration of evidence from the literature review and expert opinions. That's the important issue. So once you have questions that are formulated, you have to integrate what is the evidence based on the studies, but also what are the questions you as a clinician will ask. And then you do a first round of questioning and you ask the expert to answer. And then they have a score from 1 to 10, whether you strongly disagree or whether you strongly agree. And so each panel answered through a first round, which is web-based. And then there was even a second round to get a final answer where there was an intermediate score. In the end, you have the evidence, but then, of course, there is a big weight, which is the consensus and the questions you provide the experts and then the answers they give you back.
And how did you separate between the strong recommendation, the weak recommendation, and the no recommendation?
A strong recommendation is defined when there is at least 80% of voting members that support the position. And then when there is a mix of strong and weak options, but you are around 80%, then you can score a weak recommendation. And when the 80% threshold was not reached, then there is no recommendation.
And there were, I believe, 32 recommendations in the paper. We probably won't be able to address each of them individually. In 3 groups, the general fluid management, the fluid management in elevated intracranial pressure, and then fluid management in delayed cerebral ischemia and subarachnoid. What would you say would be the key recommendations in terms of the general management for neurointensive care patients in terms of the recommendations for fluid selection and therapeutic or safety endpoints?
Yeah, so I think we can start from the question 1, because we decided to go with these 3 main questions after a first big meeting we had during a Congress of European Society in Milano. And so it was felt that general fluid management, either when you resuscitate the patient or what you set as maintenance, then of course the use of hyperosmolar fluids for ICP control, and then the management of DCI. So starting with the fluid management, I think that one question that was extremely important and comes out very often is, what is the preferred type? And I think that we all agreed that we should prefer crystalloids. And there are data based, of course, on colloids. We have had enough evidence and also strong consensus to recommend against the use of colloids. Of course, obviously, against the glucose-containing hypotonic solutions. And then there is the chapter related to albumin, and that's something that we have a little bit to, I would say, to balance in terms of the type of disease and in terms of whether you talk about fluid resuscitation or fluid maintenance. But there is a recommendation which is strong against high-dose albumin for acute ischemic stroke. And then we suggest against the use of high-dose albumin as resuscitation fluid. So when you read the document, we have a little bit distinguished between the type of the fluid, the tonicity of the fluid, some recommendations as well in terms of type of disease, because acute ischemic stroke, there was a large trial where they used albumin high dose. And then there are much suggestion and strong recommendations related more on how to approach in neurointensive care patient volume resuscitation, fluid management, fluid balance, which I think the type and the tonicity is very important.
And in terms of the monitoring your response to therapies, I think most of our listeners would agree that you're not following a single number. I believe that the recommendation is blood pressure and fluid balance. I do notice that, again, central venous pressure has been falling out of favor. Would you say that that's correct?
Yes, central venous pressure is still, I would say, a physiological variable that can tell you something, but definitely not fluid management and targeting.
I think the section of the recommendations that will get the most interest from readers would be the hyperosmolar fluids for the treatment of raised intracranial pressure. Can you discuss the triggers to start hyperosmolar therapy for raised ICP?
Well, the trigger is a very good question. I think we suggest using a predefined trigger for starting osmotherapy to treat elevated ICP. And I think the strong recommendation is using a combination of clinical and neuromonitoring. And of course, you must monitor the intracranial pressure. As for the trigger, what we recommend strongly is a combination of neurological examination, head CT findings, and ICP. And we all agreed strongly recommending ICP above 25.
And that was ICP above 25 in the absence of clinical changes?
That's a suggestion, and it's a weak recommendation of taking ICP above 25 in isolation. Now, you can't recommend 20 versus 22, and definitely recommend against the use of an ICP threshold lower than 20, at least because we are talking about adult population.
And those numbers are some things I think that some folks will key into, because we're all biased a little bit on where we train, and many of us were brought up in places where we were looking at 20 and 22, and it sounds like the evidence favors more the 25. And I've encountered some surgeons that really, for specific cases, would prefer less than 15. So it's very interesting to me to see the recommendations from the group on those numbers.
Well, it's based on data that related ICP and outcome ICP thresholds, and also on the integration of ICP with other monitor variables like brain tissue oxygen, transcranial Doppler. So when you monitor several modalities, you actually tend to be less aggressive if is this ICP elevated or slightly elevated, but the rest of the brain looks pretty okay. I think for the general audience, we still recognize ICP, despite the limitations, as an important variable when you treat elevated ICP. But it's not the threshold on its own that should be considered, but the overall situation in terms of neurological, clinical imaging.
Despite being routine in many hospitals, hyperosmolar fluid for elevated ICP received a weak as opposed to a strong recommendation. Any thoughts on that?
Well, question one is, are hyperosmolar fluids effective in reducing ICP? Mm-hmm. And the answer is yes. And if you go and look at the figures, mannitol and hypertonic saline are effective in reducing ICP. The question two is there evidence that hyperosmolar fluids have different efficacy? One more effective than another in reducing ICP. What we cannot strongly recommend is whether mannitol or hypertonic saline, one or the other, is more effective. Weak recommendation is that you cannot decide whether one is better than the other.
That's helpful. That's helpful. Thank you. And what were the recommendations regarding fluid therapy for delayed cerebral ischemia?
Well, that's a chapter which is very thin, because there is only 2 recommendations. And we're talking on subarachnoid patients who have delayed cerebral ischemia. So you want now to treat, and what's the role of fluid therapy? The type of the fluid, the same recommendations as above, so crystalloids, even though there are some data on albumin, but still crystalloids. And then you have to apply same rules in terms of blood pressure, reversal of neurological deficits as main endpoint. And then the weak recommendation is the suggestion of what you use to monitor and what are the targets for therapy. And these are Doppler and improvements of cerebral perfusion. Notwithstanding the fact that the main recommendation is to keep euvolemia, and the fact that fluid per se cannot improve cerebral perfusion.
I did like the way that the paper described it, that based on the low level of evidence for many of the things that we've covered, these recommendations don't represent standard of care, but they recommend the current best clinical practice.
Yes, this is very important, and it's again put as a note at the end of this big table that what we came out is basically a balanced, we hope, a balanced paper providing literature review, which I think is still very important if one also wants to consider future studies in this field. Expert opinions, I think, even though I could discuss about the value of an expert, but a group of physicians who assessed all the literature and then tried and answer specific questions. And then these are purely recommendations, and so we should not just apply and consider these as a mandatory document that one, it's just what we have available and what we can advise clinicians in terms, again, as best practice.
After having gone through this process and seeing the current level of evidence out there, where do you think the ideal research opportunities to move our knowledge on this forward would be?
Well, there is something going on, at least for traumatic brain injury patient, which is the center TBI. I'm not sure that randomized clinical trial will be something if we talk about, for example, comparing mannitol versus hypertonic saline to treat elevated ICP. So I guess new prophylactic interventions may be interesting to see in comparing hypertonic versus isotonic. Secondly, there may be something to look at thinking a fluid, whether the composition, if you avoid chloride-containing solutions, use balanced fluids. Is this something that could be better? And otherwise, I think again that these large data set like the center TBI may provide information about fluid balance and may provide us with a better message.
Well, I'd like to thank you again for agreeing to participate in our podcast series. And before we leave, is there anything else you would like to add on this topic?
No, I think I would like to thank again all the co-authors and collaborators of this paper. This was definitely a huge effort and amount of work. And otherwise, I think and hope that if there are questions from this podcast and issues related to the document, please send your concerns or question to me, and I can also see whether there is something that maybe is still unclear, or even if there is disagreement on something that we have written down.
Thank you very much again. I appreciate you joining us.
Thank you.
This podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. The Neurocritical Care Society provides and advocates for the highest quality of care for patients with critical neurological illness throughout the world. Follow us on Twitter @neurocritical, on Facebook, or visit www.neurocriticalcare.org for more information about NCS and the comprehensive resources that it offers. On behalf of the Neurocritical Care Society, thanks for listening.